And certainly it's my pleasure to be here and always happy to share about the latest updates in cryo ablation. These are my good disclosures. So just a quick summary of where cryo has gone. I think it's pretty incredible. I remember when the first one I came here over 10 years ago, and thinking back to almost 20 years ago when I first performed cryo ablation, that this really has taken over quite a bit of what we have done for AFib ablation for cryo. It's over 1.3 million cases done over the 80 countries, and a lot of bodies of literature on this as well. So at least in the United States, we now have three different crab balloon systems we can look at. I understand in China there are a few more, but they're fairly similar. Of course, the very first one is what was originally from Cryocath or acquired by Medtronic, and after a few iterations, it's now called Arctic Front Advance. Boston Scientific actually then have their own version of the cryo balloon, which is the Polar X and Polar Fit that has the variable size. And Synaptic Medical is now behind and creating a new cryo balloon that's similar, a variable size as well, that's in IDE trial. I won't go through too much of the tool sets, but it's fairly similar and familiar to a lot of us. The whole idea is to be able to have a cryoablation system that engages pulmonary vein, create a circumferential lesion, and that's reliable and safe. So the tool set's very similar, and some iterations of improvements along the timeline. And Boston Scientific also has then created a similar system with a circular mapping system as well as an ablation system. And similarly, Synaptic Medical, now coined Nordica system, is also similar in the design. I'll go through some of the differences. Well, what's wrong with cryo balloon? Let's start with that. Well, cryo balloon is a fairly simple, reproducible way of creating a pulmonary vein isolation. I think what's surprising to most around the world is that how adaptable it is, even people who don't have the focal ablation hands. And maybe that's why it took off, but mostly it made it safer and faster for most operators. But of course, the whole idea of inflated blade isolate that's first coined is not quite right? Because how do you take one single balloon and create a perfect isolation in every vein? That's variable. It's not that perfect. And here I point out a typical not so perfect pulmonary vein isolation, a redo. We map with Orion high density mapping, and I point out that sometimes if a vein ostium is fairly large, you have a deep isolation. And that's typically not where we would do off, wide area circumferential lesion. And so that's suboptimal. If the veins are further apart, like this example with the right superior, right inferior, and further apart, you have an isthmus right in the middle. So over time, we have revised how to do cryoballoon ablation by doing what's called segmental isolation. So it's no longer single shot. You have to segmentally push the balloon in different direction to really get the wide area. So that's kind of how we compromise against what is fixed. So there were a lot of room for improvement. If we use the single shot in animal models, you can see this. Of course, what we typically publish is where you see where the right superior area is, nice circumferential lesion. Of course, everybody looks at this to say that's what we get every time. Well, that's what we get most of the times are like the ones on the right side or left side here, where you have a single side that's better engaged and the other side actually is not engaged so well. So if you do a single shot, it's actually quite disappointing for the most part. So how do we make that better? So over time, we realized that, of course, one fixed size balloon is naturally not great. You need to have a variable size. You can't have a high pressure balloon because then you don't engage it very well. So these are all different things that along the time that I said, well, we got to make a better design. So two balloon came out on the market now. One, we just did the first case in US last week, which is the Polar Fit made by Boston Scientific. So a major difference compared to the Medtronic is that it's variable size. So we start with a 28, you can enlarge it to 31. And yeah, second, there's no pressure shift. If you're a Medtronic balloon user, you'll realize that as soon as you start ablating, you will see the pop out or often the balloon will disengage from the original occlusion state. So what you see is not what you get. You need to compromise for that. So a lot of the shift and the workaround needed to be there that is actually now fixed by the Boston Scientific balloon. And similarly, the Synaptic Medical has a constant pressure variable size system, and we'll go through some of the differences. Why is pressure control important? Well, because cryo, like different energy source, is contact dependent. So if you shift from your original contact state, it becomes less predictable. So if you compare to the Medtronic balloon, those who are users would know that you, after the first 5 seconds of pressing a blade, often we have to re-inject contrast and see where the new leak is. If you're not aware of that, this is where people say, well, I have a good occlusion, why can I not isolate? So this is where the users become frustrated and say, well, yeah, it's not quite working the way it's supposed to be. Well, this is fixed by the newer balloons, such as the Boston balloon, which has the now called the Polar RX, which has a constant pressure. So you notice that in the 28 millimeter state, the pressure is low, stays soft. That way it engages better. Once you start ablating, that pressure doesn't change. So what you see is what you get. Similarly, this is happens for the 31 millimeter balloon, even though the pressure is slightly higher at the inflation. Ablation does not change that pressure. So there's no shifting. So there's no guessing about that. But when you make the balloon larger, of course, the refrigerant flow needs to be there to constantly make that single shot isolation. And you look at thermograms, you can actually also see that you can similarly get the anterior half of the balloon to freeze. So as long as you can engage the balloon at any antrum, the front half will create a nice freezing front. So this actually will predict a very good, nice wide area circumferential lesion. So my objective in the PolarFit trial, as I looked at the protocol, is that, we really need to look at how it really benefits as we shift from 28 to 31. So we did a whole collection of our PolarFit trial patients with more of a continuous contrast injection. So if you keep an eye on the balloon as we enlarge from 28 to 31, you'll see that it actually moves more antrally. And even some of the balloon that has a leak, like the one in right superior vein that leaks inferiorly, as it enlarges, they actually engage it perfectly. So this will allow two things. One is more proximal antral ablation that's more similar to what we would have done with wider area circumferential lesion. And the second, of course, would be to have a better engagement and better single shot isolation. So we can actually take a look at the same vein with a different size balloon and make some calculations. So that became fun because then we can see what is the true difference or added benefit of having this 131 millimeter difference. So if we try to calculate this, I won't go through this in detail, but I'll point out that if we were to look at just the laser here, oh, let me see. If we just look at the pulmonary vein that's actually able to be occluded by both, it's really approaching 85% that either side using that will get a one-shot isolation. And this is actually being very critical of 4+ isolation there with perfect contrast retention. If you look at all the numbers about being able to be occluded, we also see that the inferior veins, which you would think a smaller vein, a smaller balloon would fit better, but actually it's because of a sharper angle. Sometimes the 28 won't occlude, the 31 actually will occlude better. So about 30% plus of the time, you'll get a complete occlusion by having that option. So having the option definitely improves the single shot isolation. And there's actually a lot of computer modeling that's taking place right now, trying to figure out what's the added area that we can actually ablate in the antrum. So if we take some calculation, when you have a nice fellow to task to and say, let's bury you in the lab and start making calculations, we can actually calculate all the ones we actually have go from 28 to 31 and calculate that we actually increase the antral area of ablation by almost an average of 2 centimeters squared. So as you know, more antral modification you can make, probably more substrate you can modify, right? And more evidently by Dr. Makati, who actually mapped this, and we do this in every ablation we do now just to collect data, is that compared to 28, 31 do take out quite a bit of the antrum, and often is really what we like to see. So there are other tools too that came about, right? Going along how to do zero fluoro cases. You can marry this to 3D mapping. So Cardo came out to say, well, we have what's called a Cardo lasso star nav. And when we compare it to the pentaray, it's also able to basically use the guidance of a magnetic-based system, create a geometry mapping, pre and post map, almost as good as the pentaray. Synaptic Medical make one big improvement there is that, as you know, those who have done the mapping with the Achieve catheter or the Boston system would see that the electrode in the circular mapping is actually fairly widely spaced apart. And so one improvement that Synaptic made is to make that closely spaced. So at least time to isolation as you're in a less superior pulmonary vein can be better differentiated from the appendage signal. And sheath actually are all improved. As we know, this is a very much a sheath-based system. So there's a lot of good improvement in sheath with minimal step up from both Boston Scientific and the Synaptic systems. Now, one thing you saw in the chart was that Synaptic system and Boston system both have two sizes, but one big difference is one's a single layer balloon, the other one's double layer balloon. That makes you worry a little bit, right? Because you think about, well, what if the balloon ruptures, right? So there are different ways to monitor for the balloon leak, and I won't go through all the detail about how it monitors the pressure and different material and different bonding and construction. But all that aside, they said, well, what if all fails despite all the checks you have, all the electronic in the balloon, sensor in the handle, and other sensor in the console? What if it fails? So if you take a blade and slice the balloon while ablating, so you have the worst case scenario, you actually get about 65 cc's of volume escape in the Arctic front balloon because it's actually a high pressure system. So if you slice that on the synaptic balloon in the 28 millimeter state, you get 12 cc's. And even in the larger balloon state at 31 millimeter, it's at 28 cc. So it's still less than half of what you see with the Arctic front system. That's actually a lot more reassuring because, at least from what I know, I reviewed 6 cases of double balloon rupture in Medtronic and no consequences actually resolved because the refrigerant actually fairly readily absorbed. But having less gas definitely is helpful. Softer balloon also helps, so better engagement, better antral modification. I won't go through too much of that. So this has become a very similar system, right? You take the balloon, engage in the antrum, and you freeze, watch it isolate. And it's actually a fairly relaxing procedure. If you have ice, you can do it completely zero fluoro. When we did the synaptic animal study, we used in 6 animals, and it's actually great that we saw 100% complete isolation with no collateral injury, no pulmonary stenosis, which is actually a feat in the canine model, because canine model, if you actually put it a little deep in the vein, the inflammatory process in dog actually is a little bit different. It actually is easy to cause pulmonary vein stenosis. We actually had to do quite a bit of explanation for Boston Scientific because in the animal model, they actually placed it very deep and actually saw PV stenosis if you ablate deep in the vein. So necropsy is always fun to look at. It's also great to see that the engagement, if you do enough of these cryoballoon cases, you'll see that this is actually a very nice antral modification when you slice it open in the upper veins. So that's actually nice to see. So all these improvement with low pressure balloon, variable size, actually has improved the outcome, hopefully. So everybody, when I talked about the cryoballoons, I've talked about PFA. No, honestly, when people come to my lab, it's like, gosh, they're surprised I do just percentage of my case with cryo. Yeah, we do every tool possible under the sun, right? And of course, we do whatever is safer or faster. Well, of course, we do quite a bit, and we've done quite a bit of different trials. Honestly, I think it will eventually get there, but it's not quite all there yet. We all want to be able to see, take a persistent patient, for vein isolation, posterior wall. Can I do that with balloon? Sure, people see me do that, but it takes a while. If I can do that with PFA, that's great. So we were part of the Avon trial. So one thing that we were eagerly awaiting, it was just announced last week or the week before at European meeting, was the Avon trial. Right? So that's the PFA versus the thermal ablations. So the PFA Fairwave, which I think is a very mature system that we really like, and against the cryoballoon and RF ablation. So I think we probably reached the asymptote or apex of what we can do with four-vein isolation. I think you take a good operator, you give it any tool, you do four-vein isolation, yeah, we get about 70% success rate. So I think if we're to focus on any differences in what anything can do, really it's just the flow and what the operators can do to replicate this four-vein isolation. So frozen AF trial I'm familiar with because we're intimately involved. And so 325 patients, 1 year freedom from AF was presented at New Orleans Heart Rhythm was 82.7%. Not bad. I think the 31 millimeter balloon hopefully will have a better outcome, but this is a sub-study there, and 6 months freedom from AF is at 88%. So hopefully it stays around the projected highs, freedom from AF, and certainly if we have a good reproducible procedure for skill level of all EPs, be able to four-vein isolation, safely isolate all four veins, get this type of result, that would be great. I think if you look at what we have seen with PFA so far, I won't belabor that, but it's been a little disappointing, I think partly because we quite oversimplify what PFA can do as well. I think still need to be contact dependent, be able to track where the lesions are, and be able to create a nice lesion. We have a lot of redos, as part of what we do. And so far, this is a PFA, PVI, and posterior wall that we isolated acutely just a month before. And you can see all the recovery we've seen so far. And I think we still have a lot of things to learn of what PFA can do. Similarly to how cryo started, similar to how RF started, I think eventually it will get there to become a nice, safe procedure. One thing that does worry me that I think one cryo has an advantage is silent ischemic event. I think compare RF, cryo, and PFA. Certainly one thing we see so far is that cryo energy is fairly elegant in that way. It doesn't create a lot of coagulum. So at least so far, the silent ischemic event compared to PFA and RF has been relatively nice. So in summary, I think a lot of advances has been made along cryoballoon. I think especially with the new system coming out with Boston Scientific that can shift pressure from 28 to 31 and maintain low pressure to have a wide area circumferential lesion. Similarly to what Synaptic Medical has done, I think that will take over quite a bit of what we can do with cryoballoon to do a reliable four-vein isolation amongst all skill levels. And I think overall, the single shot rate will be higher. We can reduce the phrenic if we are a little farther away from the right superior vein as well with a larger balloon. And the wider circumferential lesion hopefully will lead to a better clinical outcome as well. And one thing I didn't mention is as we started doing PFA and other systems, sedation. Right? Cryoballoon system are often done in even China. I've seen many labs do it fully awake. Definitely to do that with PFA and RF is a little cruel. So I think different clinical flow, different advantages. I think anything that's safer, faster for our patients is all good news. Thank you.